Hello everybody, Dr. Gillard here once again. This is week 10 of winter 2020. School is basically shut down except for lectures which are given online and tests are given online. Crazy times, right? With this virus circulating throughout the world. Nevertheless, we shall move forward. And we have an important lecture today in cardiovascular and pulmonary pathology. We're going to discuss Wolff-Parkinson-White Syndrome and AVRT and AVNRT, the number one and number two most common causes of supraventricular tachycardias. So let me turn on my laser pointer here. All right, here we go. Let's start out with Wolff-Parkinson-White Syndrome. It's hard to talk about Wolff-Parkinson-White Syndrome without talking about AVRT, Atrioventricular Reentry Tachycardia. Kind of go hand in hand, but try to do the best we can. It's kind of hard to separate the two. But anyway, so Wolff-Parkinson, we've talked about that for a long time because it's such a common problem out there. And we talked about the accessory conduction pathway in the fibrous skeleton. Even before that, we talked about the fibrous skeleton. And it's kind of like a gasket. If you know what a gasket is, like a head gasket on a car. It separates the atria from the ventricles, but it has holes in it where the AV valves and the semilunar valves pass. One of its jobs is to keep electrical signal from the atria from sneaking into the ventricles ahead of their scheduled time. Remember, once the SA node depolarizes, the current spreads over the atria pretty evenly and quickly, but it prevents anybody from sneaking in it. The current has to go through the AV node, specifically the slowdown portion of the AV node, which will give the atria time to contract to fill off or top off the ventricles with blood. So that little delay through the AV node is important. And on EKG, what does that delay represent? We're going to talk about that a lot. Close, not the PR interval, right? It's the PR segment. It's that flat line. I wonder if I can draw here. Never tried to draw. Probably going to mess something up. Well, I won't draw. But you know what I'm talking about. All right, so that's important. The P wave plus the PR segment, the flat part, that's the PR interval. So accessory conduction pathways, if we sneak in the ventricles ahead of time, there goes your PR segment. The flat part is gone. And the QRS segment is wider than normal because normally the QR segment isn't where the PR or the QR interval or the QR complex is normally not where the PR segment is. Anyway, we'll get to that. So Wolff-Parkinson-White syndrome is an accessory conduction pathway, which is just a hole. Well, it's more than a hole though, but it's a hole through the fibrous skeleton. It's not supposed to be there. And that hole is filled with usually some very fast conductive fiber, faster than the bundle of His, for example, or the bundle branches. It's very fast. Those fibers were discovered by Kent, and therefore they're called the bundle of Kent, or Kent's bundles, okay, or Kent's fibers. They all Wolff-Parkinson-White syndrome, accessory conduction pathway system, Kent's fibers, delta wave, all should be memorized. We'll get to delta wave. Right, so Wolff-Parkinson-White syndrome, here's what exactly I was talking about. SA node, AV node is here. Penetrating fibers of the bundle of His splits into a right and left bundle branch here, which goes into the Purkinje system. Pretty fast superhighway here. Not supposed to be, you can't really see. I mean, here's a piece of the fibrous skeleton here. It would be on the rim of this. This is all fibrous skeleton separating the atria. Of course, we know the atria, right? Right atrium, left atrium, double hold. But here we have a hole in the fibrous skeleton. It doesn't have to be here. It could be here. It could be over here. It could be anywhere. Just drew it over here to make things easier. But it might be here. And inside the hole are filled with Kent fibers really, really fast. So you can imagine what happens when this sends a spark across. We can get some of the fibers coming down, or some of the action potential comes down this way via internodal pathways. Instead of turning and heading toward the AV node, they go, oh, a hole. Let's go down here. And they, quote, pre-excite the ventricles. They sneak into the ventricles ahead of time, and this region starts contracting. That's called pre-excitement, ventricular pre-excitement. Right? So all these accessory buzzword, all these accessory conduction pathways, quote, pre-excite the ventricles. Okay, I said we can't talk about Wolff-Parkinson-White syndrome without talking about AVRT. So most patients with this hole, actually about 80%, so most patients, 80% of patients who develop the second most common cause of a racing heart, that's called Atrioventricular Reentry Tachycardia, which we'll talk about here in a second, they have Wolff-Parkinson-White syndrome. We'll talk exactly about how that goes in a second. But not all patients with Wolff-Parkinson-White syndrome, they don't have to develop this tachycardia. Okay? It's not, I think it's about 50%, but we'll see that number in a second. What's the electrical sequelae of Wolff-Parkinson-White syndrome? Well, it's not a heck of a lot. I mean, clinically wise, the patients usually don't even know that they have it. It's just when their heart goes into that really fast beating, that AVRT, that's when problems happen. But the electrical sequelae is, well, typically the AV bypass tract, or the Kent fibers allow a small portion of that current to sneak through it and get into pre-excite the ventricles. We're going to call it, just for the heck of it, the rebel current. Rebels are groups usually that overthrow the government and they invade and they're troublesome. And that's exactly what this current, the Wolff-Parkinson rebel current. And most of the SA generated current goes its usual way. But that rebel current beats the normal SA generated current to the punch. It gets into the ventricles first. And therefore, it gets the AV node, or the normal current has to go through the AV node. Therefore, it gets delayed while the rebel current is marching. But not to fear, the normal current will prevail in most cases. Do I have a picture of that? Yeah, one's coming here. But I mean, we can go back to this, so, and I'll reinforce this in your brains here in a second. But just imagine the electrical current spreading out all over the place. And some of it sneaks down here. Not all of it goes down there. We still got current hitting the AV node slowdown portion. Okay. And maybe this current has made it to about here. This current is finally going to get released from that slowdown portion, and it's going to rip through here super fast, and these two currents are going to collide right here and snuff each other out. That's kind of the key of the story here. Normally that's what happens in these patients. Okay, and that's just what I said. When the rebel current sneaks into the ventricles ahead of time, that region of the ventricle is pre-excited, right? Ventricular pre-excitement. Said that already. And there goes the PR segment, right? The PR segment, this kind of came out in small letters, didn't it? It wipes out that PR segment, and it's replaced by a delta wave. So the QRS complex has started ahead of time. Show you a picture in a second. Luckily, the rebel current does't have access to the Purkinje system, or it would go super, super fast. But that's not always going to be the case, as we'll see in a little bit. So the rebel current moves very slowly. It doesn't have that big, the bundle branches and the Purkinje system to work through. it goes very slowly. It has to spread cell to cell, myocardial site to myocardial site, and they can pass through gap junctions. They can pass the electrical signal, but it's a slow process. They're not going down the superhighway, so it's slow, and that's a good thing. Okay, so now we got some arrows drawn in here, so just what I tried to say. So here's a patient with Wolff-Parkinson-White syndrome. Probably doesn't even know he has it. So the SA node sparks an action potential. Shoots across, what's that called up here? I didn't draw it in there, but Bachmann's bundle. Super fast, right? It's almost like you have two SA nodes. So it pops up over here on the left, the action potentials. Everything is depolarizing the heart here. There's some internodal pathways. Signal's going to get into the AV node, but the signal via this internodal pathway, which I didn't, if you don't know about the electrics of the heart, I have a YouTube video you should probably watch if you're completely lost. But look, some of the signal snuck in here. So normally it got here, but it gets held up here, right? The AV node's job is to hold the signal so these atria contract. But there's nothing to hold this one up. So the rebel current marches on and it goes further and further and further. But not to fear, as it about here, finally the normal signal is released, goes down the bundle of His, down the bundle branches. Same thing's happening on the other side normally. There's the left ventricle in this case is depolarizing, normal. Contracting is normal. But this current comes flying around and there's a collision between the two currents and both currents are snuffed out. So this current can't go any further. Couldn't anyway because this tissue is already depolarized. It can't accept another. Can't accept an action potential anyway. So they're snuffed out here. Maybe the patient feels a little palpitation here. Maybe they don't. They probably don't. Maybe if some cardiologist watches this video, he can say below, do they usually feel palpitation? There's no books I read on that that say, I haven't found any research that shows this collision causes a PAC, but it makes sense. Maybe there is one. All right, so that's Wolff-Parkinson-White syndrome. Every beat of the heart, the same thing happens. But does it affect much? Not really, because in this case, the left ventricle is still working the same. Timing is off a little bit because we have a pre-excited right ventricle here. But it's still getting depolarized, so there's still a contraction. Maybe they might lose a hair of ejection fraction on the right ventricle. I don't think enough, even a top level athlete probably wouldn't even notice it. All right, so what about the usual presentation of this on EKG? Well, the super slow rebel current shows up. It replaces the quiet patch on the EKG. It replaces the PR segment. And instead, it makes a slow kind of slurring of the R wave, it's said to be. Sometimes it bulges out. Remember we said the QRS complex has to be built with straight edges. We usually don't get a very straight edge with this, and you get a bulge. And that slurring of the R wave is called a delta wave. So remember, that's a key word to remember. Wolff-Parkinson-White syndrome, AVRT, delta wave, all key things to remember. Kent fibers, all key words to remember. So here's a normal beat of the heart where we have a P wave, but normally we have a nice long QR segment, or this is the PR segment right here, and this one was cut short. Sometimes you don't see this at all, but in this cartoon, this certainly was not built with straight edges. See how these are nice and straight here? But then we got this hump. This hump, normally the PR segment should be right here. So therefore you get no PR segment and a shortened PR interval. Remember, the PR interval is the P wave plus the flat PR segment. So if we measured this out, this would be, the QR complex would be too wide. Remember, it shouldn't be more than 2.5 little boxes, 2.5 millimeters, or 10 seconds, whatever you want to say. But this one is, so you get a wide QRS complex with a delta wave. Got it? What causes the delta wave? Well, this is where the rebel current, where's the rebel current? Right here. This right here, delta wave starts. Delta wave, delta wave. That's the end of it. That's the delta wave. Got it? Okay, and we said this already. What happens to the majority of the current? Well, everything I said. It got slowed up in the AV node, but then it's off to the races as normal. There's a collision. The rebel current is snuffed out. Already said that, right? We already looked at that. So what are the symptoms? Patients may experience palpitations. They may not. They probably don't. There's no other symptoms except for that. How about on the ECG tracing? How about on an EKG? Yeah, we can see the delta wave. The QRS complex is going to be too long, and the PR segment or PR interval is going to be too short. Right? Simple. So the usual EKG findings of Wolff-Parkinson-White syndrome, simple. Delta wave. Okay, that's going to make a widening of the QRS complex. It'll be 3-4 millimeters, 3-4 little boxes wide in EKG. If that's too wide and the PR segment was taken out by the delta wave, there will be a short PR interval. Probably will be no or a very short PR segment. The RR intervals are going to be normal. These are not ectopic foci, PJC, PAC, PVC. We said those can make irregular. Same with, what else makes an irregular, what's that? Irregularly irregular RR interval. Come on, who is that? Atrial fibrillation, good. I heard somebody. Was that you, Katie? That was Katie who said that. Or maybe the no-name woman. Anyway, it's better to do these lectures in person, isn't it? But nevertheless, what are we going to do? Here's another tracing of this. Right, so normally that would be a PR segment right here. That's wrong. That shouldn't be PR interval. That's the PR segment. But it's gone. This one, a little trickier, right? There's not a nice little hump there. But there's a short PR interval, and if you measure this, it's a wide QRS complex. It's got to be Wolff-Parkinson-White syndrome. All right, 44-year-old female enters your tent. You're working at a bike race or something, and you're one of the very few. I mean, you would have, right, this little class I'm giving you is not nearly enough to make you proficient at reading ECGs, but it'll give you a taste of it. You know, I know you'll be right up there with an RN level because my daughter is an RN and I know her abilities, and we are probably above her abilities on these things. They don't have that much teaching in how to read these tracings. But anyway, I digress. So a 44-year-old comes into your tent, says heart was racing about 30 minutes after the race and she freaked out. She wanted to get checked. She feels a little better now. What do you think of this tracing? Well, what's the first thing you do? Well, a couple things. You can get the rate of the heart. I like to look and see how the RR intervals are, just kind of eyeball them. There's a peak of the R wave, peak of the R wave, just roughly 1, 2, 3-ish. That would be 1, 2, 3-ish. So yeah, they look pretty 1, 2, 3-ish. They look about normal to me. How about the rate? Let's see. Here's a good one. Let's see what the rate is. So remember the bowling rule? 300 is a perfect score. So there's 300. It ain't 300 beats a minute. It ain't 150 beats per minute. And ain't even 100 beats per minute. It's under 100. So this is not a tachycardia. Okay, so we can cross that off our list. What do we got here? So we got a T wave. We can see we got a P wave. Now the thing that catches my eye and your eye is if that's the P wave, it's upright, so that's good. It's not a premature junctional impulse or anything. What about this right there? Is that a straight line? It's subtle, isn't it? But if you apply your rules, actually in this one, two, how big is the PR segment? Right, 3 by 5 it should be. That's actually looks about normal. 1, 2, it's pretty close. 3, but I don't see a PR segment. Right, remember the other rule about the PR interval? It's got to have a PR segment. I don't see one. And plus, this is way too big. Right, here's the start. This should be no more than 2.5 little boxes. Starts about here. So I probably blew this up on the next slide, but it's 1, 2, that's over 3 little boxes. That's too wide. So we have a short PR segment or PR interval, and we have a wide QRS complex. This is Wolff-Parkinson-White syndrome. There we go. I measured it up. So everything I just said came out to 93 beats. If you do the 1500 little box rule, comes out to, you guys know all that. I'm not going to go over that again, but well, I will. Some of you people may not know that. If you want to find the heart rate, get your iPhone out, count the number of little boxes. So we'll use this one. There's 5, 10, 15, well, it's like 16 little boxes. So 1500 divided by 16, 93 beats per minute. That's more accurate than the bowling 300, 150, 100, etc. Memorizing those. That's good for finding a tachycardia though. Yeah, so everything I just said, so I measured it out, so it was definitely over the maximum 2.5. So yeah, Wolff-Parkinson-White syndrome. That's a delta wave. It's more subtle than we've seen before though. So Wolff-Parkinson-White syndrome, what happened, they probably went into Atrioventricular Reentry Tachycardia, AVRT, after the race, and it petered out and went back to normal. That's probably what happened. It's probably a very common story. This one's a little easier. 22-year-old football players in your office, complaints of racing hard after football practice, feels okay now but wants to get checked, do a heart exam. Everything sounds okay with the ticker. You say, let's run a tracing on them. Run EKG tracing. Here's what you get. Okay, same analysis. I won't go in detail, but that's definitely our intervals. And this I could have put 3 dots. This goes on and on. Our intervals are great. T wave is sometimes high in the young people, so that's not anything to worry about. But where the heck is the PR segment? Right? Where there's supposed to be a flat part. Right? That's where the current is going through the slowdown portion of the AV node. There's none. And this is a much better delta wave here. So this is another patient, and you just diagnosed him correctly with Wolff-Parkinson-White syndrome. And what happened to him? He went into AVRT after practice. So what do? Refer him to the cardiologist. Let the cardiologist do a stress test and an ultrasound and work him up. Remember, that's your chiropractors are primary healthcare providers. You need to act like one, so make sure you refer him. We refer patients to where they're supposed to go. That's our due diligence. You can get in trouble if you don't do stuff like that. Right, everything we said here. All right, pretty easy one. Now let's talk about a little more specifically about this AVRT, or Atrioventricular Reentry Tachycardia. Sometimes it's called Atrioventricular Reciprocating Tachycardia. Yeah, that's right. Yep. Okay, so it's the second most common of the supraventricular tachycardias. Remember, I gave you a list that you should know the supraventricular tachycardias. Who are some of them? Who are the other ones? Who have we studied? Good, Carol. Good. I heard your brain saying atrial flutter, atrial fibrillation. Oh, we didn't do atrial flutter this time. Atrial fibrillation we did. EAT, ectopic atrial tachycardia, junctional tachycardia, atrial flutter, atrial fibrillation, and now we come to AVRT. Good. Second most common, usually seen in patients with Wolff-Parkinson-White syndrome. There's other conditions, other it's always seen in someone with a bypass tract. But remember, there are other types of bypass tracts besides Wolff-Parkinson-White syndrome. We talked a little bit about Langerhans-Levin syndrome, which has, I should have put that in here, but you get some fibrous highways that run from the atria and they attach to the distal AV node and bypass the slowdown portion. That's Langerhans-Levin syndrome. You can also get AVRT through that. But for the most part, 80% of the time, it's seen in patients with Wolff-Parkinson-White syndrome. At some point, we said this already, about 50% of patients with Wolff-Parkinson-White syndrome will develop a supraventricular tachycardia called AVRT. And we kind of, oh no, we didn't really talk about it, but it occurs when you get a looping racetrack that goes, usually it goes backwards through the Kent bundle, the fibers of Kent. The example I showed you, we had current moving anterograde through there. But if you want a tachycardia, you move backwards anterograde through that accessory conduction pathway. And you can get a pretty fast racing heart like that, and we'll explain that here in a second. You can also, people with Wolff-Parkinson-White syndrome, they do get other tachycardias, like atrial fibrillation and atrial flutter. And can they get, yeah, they can get EAT as well. They could probably get junctional tachycardias as well. But most of the time, they're going to get AVRT. Let's dig a little deeper. There are two types of AVRT. By far, 90 to 95%, depending on the author, we'll say 95 for our purpose percent of the time, it's orthodromic AVRT, where the current runs, now listen to this, retrograde through the bypass tract, through the Kent fibers, and runs anterograde as normal through the bundle, through the AV node and bundle of His and bundle branches, all that stuff, Purkinje system. Okay, occasionally, rarely, hard to reproduce in the lab, I've read, they can get the opposite. They can get an antidromic AVRT. People die from this one all the time. This is really, really dangerous. It runs retrograde through the Purkinje system bundle of His AV node backwards. If you run a current backwards through the AV node, that slowdown portion doesn't work. The current just zips right through there. So you can see why it's dangerous. And therefore, it runs retrograde and runs anterograde through the accessory conduction pathway. Everybody good with that? How does this start? Remember we talked about PACs? We didn't get to talk about, we talked about PJCs. We didn't talk about PVCs, premature ventricular complexes or contractions, whatever word you want to use. But it's the same principle. Your ventricle myocardium, you can have a kind of a wild, crazy group of cells or just one cell that beats the SA node to the punch. And so that can spark and run the heart. And that's exactly what happens in Wolff-Parkinson-White syndrome. We get a premature contraction of a group of ventricular myocardia. It could be anywhere. It doesn't have to be here. But we'll use this because we haven't talked about this. So let's go. Do we have a picture coming? So we get an ectopic foci that occurs right in the pathway of one of the loops. Either it snuffs out, it collides with the rebel current and knocks it out. That's what causes orthodromic AVRT. Or the PVC or whatever, the ectopic foci, if it knocks out the normal current, then there's nothing to stop the rebel current. The rebel current can actually run retrograde through the Purkinje system. And when I say Purkinje system, I'll just include the AV bundle of His, the AV node in that system. That's a bad thing. That's antidromic AVRT. That one, thank goodness, that one's pretty easy to see on ECG tracing. Okay, so let's take a look at it back to our picture. So this is Orthodromic AVRT. And what has happened is, so we got a normal SA node spark of the heart. So Bachman's bundle, everything in yellow here. I should have put these in yellow as well, but then it gets too confusing. So this was part of the normal spark here. This is just the rebel current as usual. No big deal. We've talked about this. Usually there's a collision here. So as usual, the rebel current goes down the Kent fibers and is marching. Delta wave occurs. It's marching in the right ventricle in this case. The regular current, or SA node generated current, goes through the AV node. It gets held up for a minute. It gives time the rebel current to march forward, but then it gets released and it goes lickety split down the Purkinje system. But something happens while it's hung up in here, and normally they would collide here, right? But while it's hung up in here, something else has happened. Perfect storm. A PVC occurs, premature ventricular complex. So this group of myocardial cells, they said, we're sick of being told what to do. We're going to run the heart. SA node, AV node, F you guys. We're running the heart. They spontaneously depolarize quicker than the SA node, quicker than the AV node, and boom, they're alive. They send out a spark. And the minute it is created, the spark doesn't have time to go anywhere because here comes the rebel current and there's a collision here. Both of these two guys are snuffed out. Okay, knocked out. So no more rebel current, no more PVC current. So here comes the normal current. Okay, getting ready for the collision, but hey, there's no collision. Where's the rebel current? These guys say. I don't know, but there's no rebel current. Therefore, if this stuff has repolarized, I mean, some people, this might be still hasn't repolarized and the current wouldn't go anywhere. But if it's repolarized, if they're fast repolarizers, the current goes, hey, let's keep going. And it flies right up and says, okay, get ready. We're going to hit the fibroskeleton. And that says, oh, look, here's a hole through the fibroskeleton. And this normal current runs backwards and enters the atria, which is already depolarized. It's waiting the next spark from the SA node, but it's not time yet. So it goes, okay, let's take off. So it's just like an SA node's right here being sparked. Some current goes and hits the SA node and knocks it silly, so it can't depolarize. Some of the current's heading this way and goes, oh look, let's go this way. And it goes right back down the AV node, anterograde, right? That's the normal way, thank goodness. So therefore it has to be slowed down a little bit by the slow down portion of the AV node. But then it's released and the same thing happens. The SA node was knocked silly, so it's not going to generate another rebel current, right? It's just stunned. And there's nothing to stop this from racing around in a circle. And how fast it goes depends on the slow down portion of the AV node. I mean, some people, these ventricles can contract over 200 beats per minute. It's not a super comfortable current in most people. All right, and there's the cartoon again, and it's just showing it's going around and around, everything I just explained. So, all right, everybody good with that? No more questions? Email me, of course, if you have questions. I can't really hear you, right? Right, Marco? That's true. Okay. Orthodromic AVRT. So everything I said, AV node is still working, protects the ventricles from fatal overstimulation. Because I mean that current probably could go 300-400 beats per minute, but it's not allowed to because of the slow down portion. So I mean the ventricles on average, and every author seems to have a different idea what average is. Garcia says it's around 180. So that's not comfortable, right? That's your heart's really cranking out. So you're definitely headed for the ER if it's going that fast. Some people maybe it's down around 140, but that's not the norm. Right ventricle's running 80, so definitely a tachycardia. It's called a narrow complex tachycardia, so it's not going to be the QRS complex is not going to be 3 or 4 little boxes long. The P wave often comes after. It could come way after the QRS complex. It doesn't have to. I mean, one author I was reading last night, he says it's really hard to tell the difference between orthodromic AVRT, junctional tachycardia, and even AVNRT. They can all look very similar. So going with Garcia mostly here, who seems to, and there's other authors, Shu, I guess you pronounce that. They think there are ways to differentiate it, but in reality, I mean, as long as you refer to a cardiologist, that's all we're not cardiologists, so we don't have to worry about that. But the P wave for our purposes, look for a P wave that's way late. It might be even notching the T wave a bit. In fact, if it's so late, instead of you can actually have what's called the RP interval, or I've heard some authors call it a negative PR interval, because P wave is usually, I mean, before the QRS complex, before the R wave, right? But it could be after, way after, and so you have a RP interval in some cases. And just like a junctional tachycardia, sometimes it's actually hidden. You might not see anything, and if that's the case, super hard to tell apart from AVRT. But really, from a junctional tachycardia, it would be hard as well. Don't worry, on the exam I will make things very clear, so you'll be able to pick it out. P morphology, reading some texts say that the P wave depends on where the hole is in the fibrous skeleton. If it's in the right atria, like in our example, the P wave tends to be upright. If it's in the left atria, it tends to be inverted. Will a patient with, I have asked this question before in the test, will a patient with Wolff-Parkinson-White syndrome have a delta wave while they're in AVRT, while they're in the tachycardia? No, right? No. The current is running backwards in orthodromic AVRT. So there's no rebel current, and rebel current was knocked out by the premature ventricular contraction or complex. So QRS complex is also typically normal. In fact, it might be narrow. Orthodromic AVRT versus junctional, very difficult to tell apart. For our purposes, and from Garcia's teachings, it seems on average that the orthodromic AVRT runs much faster than junctional tachycardias, and that's the best way to tell. The inverted P wave may be much later, near the T wave in orthodromic AVRT, so look for that. But for our testing purposes, if you see one running 180, even 150, 160 beats per minute, it's going to be orthodromic AVRT. If it's running 120 or so, it's going to be a junctional tachycardia. So we'll keep that distinction. But in reality, it can be really difficult to tell these apart. Here's an example of a orthodromic AVRT, a cartoon of it. So we can say QRS complex, T wave, no P wave. The P wave is actually way, way late. So you could say that they have a long RP interval. It's so late. It's starting to notch. It's not slurring the S wave. It's way late. It's actually interfering with the P wave here a bit. So these patients are said to have a long RP interval. No delta wave, right? Because we're in a tachycardia. So there's no rebel current. The rebel current was knocked out. It doesn't exist. How about this one? 55-year-old male comes in your office complaining of a racing heart. He doesn't know what happened. What do you think of this tracing? Well, is it a atrial fibrillation? No way. We can see a huge T wave. You wouldn't see any T wave in AFib. Where's the P wave? We don't see a P wave, or do we? Well, let's go back to our RR intervals. Look pretty good to me. What's the speed of this guy? We can use this one here. There's would be 300. There's 150. Ooh, this one's really moving, isn't it? This is probably 170, 180 eyeballing it. So this guy is really, I mean, right, this guy goes to the ER, right? This is too fast. You don't wait around to send him to the cardiologist, send him to the ER because he's got some type of supraventricular tachycardia. Okay, so 188 beats per minute. Where's the P wave? There's no P wave. It's hidden. I mean, so for our testing purposes, what I say, if it's going more than 140, 130 beats per minute, it's not going to be a junctional tachycardia. It's going to be AVRT. And that's exactly what this turned out to be. So it looks like a junctional tachycardia, but for our purposes, it's going to be too fast. In reality, it might be a junctional tachycardia. It's pretty hard. The cardiologist or electrophysiologist is going to have to come in and who've been studying this stuff for years. I mean, we're just scratching the surface of this with this class. Orthodromic AVRT treatment, the same treatment. So vagal maneuvers are attempted. Some research I was reading actually last night. There's a 27% chance of stopping this. That's a good number by a simple carotid massage. So all the turning up of the vagus nerve, either by stimulating the vagus nerve, the gag reflex, Valsalva's maneuver, carotid massage is probably the best to try. Remember, don't do it bilaterally. Start on the left side first and then try the right side. If that doesn't work, then they give IV adenosine, 91% chance of stopping. This almost always works. You can do some IV metropolol, which is another possibility. Really good for controlling pesky little premature complexes. And then at the last resort, usually not needed, but you can pull out electrocardioversion therapy, and we've talked about that already. All right, let's talk about the other more dangerous one. This is called Antidromic AVRT. This is a bad one. Luckily, it's rare, but this can kill the patient. So very dangerous. And these are all considered macro reentry circuits, even orthodromic. Anytime you have a current that's going in such a big circle. Remember we talked about the difference between micro reentry and macro reentry already. So this occurs when the current, the SA node generated current, it gets knocked out by the ectopic foci. And the Wolff-Parkinson-White rebel current doesn't have anybody to snuff it out. And it runs backwards, retrograde through the Purkinje system, through the bundle branches, through the bundle of His, through the AV node. And if you remember, I said if you run backwards through the AV node, there's nobody to oppose you. Not good. So there's nobody to slow you down. This thing can run super fast. Let's use a premature atrial complex ectopic focus right here in the right atria. So SA node current is generated heading Bachman's bundle, but the one headed for the AV node, a perfectly timed pack pops up and collides with this part of the current. This current would have went down the AV node like normal in a normal Wolff-Parkinson-White patient. If it would have, we would have had a collision right here, and both the rebel current here would have been canceled. Right, just like before. But this time, there's nobody entering the AV node in time. This is over here in Bachman's bundle. This one normally would turn, maybe head toward this. Yeah, but there's nobody to stop the rebel current. And maybe this is really fast Kent fibers. And no collision occurs, and these guys get in to the Purkinje system, and now they can go backwards pretty darn fast. And there's nobody stopping. There's no slowdown. Does not work going backwards. And it pops out here, and you might as well make this the SA node. The current it goes everywhere. I didn't draw it in. It can go this way, it can go this way. It goes this way, knocks out the SA node, so the SA node is knocked silly and doesn't work. But it goes right back down Kent fibers, and if they're fast repolarizers and ready to accept another action potential, here we go. We got a macro reentry circuit where the current is running retrograde through the Purkinje system and anterograde through Kent fibers. That's going to be the key. That's how the question is going to be prepared. Make sure you know retrograde versus anterograde, right? Very, very dangerous type current. And then just a continuation. It goes around and round, and nobody can stop it. Do you see why Valsalva's maneuvers might actually stop this one? Remember we talked about ectopic atrial tachycardia, where let's say this guy's running the heart at 160 beats per minute. If you do Valsalva's maneuvers, it stimulates this to slow it down, but it can't stop it because the source isn't through the AV node. But both of these AVRTs, although you don't want to ever do carotid massage on these people, but on orthodromic, I'm talking about orthodromic, when the current's going the other way, you can actually stop it. This one you could kill the patient if you do, so you got to run an EKG. We'll come to that in a second. Why is it dangerous? Because the slowdown portion of the AV node is taken out of the play. So the ventricles they can run full blast. They can run over 200 beats per minute. On EKG, thank goodness that there's an easy finding. It gives rise to a wide complex tachycardia, it's called, because the QRS complex is very wide. It's using slow cell-to-cell spread, the rebel current at first, so before it goes fast, so it strings out the QRS complex because of that slow cell-to-cell spread. Ventricles typically run above 200 beats per minute. It can be fatal. It can run up to 350 beats per minute and kill the patient before they even get to the hospital. So very deadly type of supraventricular tachycardia. So EKG findings, again, a wide and bizarre QRS complex, greater than 2.5 little boxes. The P wave usually is late, so sometimes this is really confusing with junctional tachycardia, right? Because the junctional tachycardia, you can get a slurring of the S wave, same with this one. So this can really look like a junctional tachycardia, only way faster for our purposes. In reality, most of the time, it's junctional tachycardia won't run this fast. Again, if you're a cardiologist, please correct me if I'm wrong down below. So 45-year-old comes into your tent after a marathon, can't catch his breath, run an EKG tracing. What do you think of this? Whoa, right? The axis is screwed up for sure, right? We won't even get into that. We almost got a biphasic on limb lead too. But nevertheless, that's way bigger than 2.5. That's not even the whole part of it there. So yeah, we got a very extra long, extra wide. You've never seen anything like that before. Put that in your brains. If you ever see that, you call the ambulance over. Let them take it from there. That guy needs to go by ambulance to the hospital. That's too dangerous. How fast is it going? We can pick this one as fine. Look at that. So one little box before the big box. Almost 300. I mean, this thing is going way over 200 beats per minute. So very dangerous. Right. There's a close-up of it. Those of you wonder where the T wave is right there. The P wave is really hard to see. There's a notching. So we have a slurring or a notching of the S wave. This is the up limb of the S wave coming back to the isoelectrical line. That little notching is the P wave. All right. Turned out to be running 235 beats per minute. I mean, you can't live too long like that. Your coronary arteries are not filling with enough blood and your heart's becoming ischemic. I think I said everything I need to say there. Final warning, Garcia talks about with pharmacological conversion and vagal maneuvers, they will have no effect when on the bypass tract. Why? Well, it's running backwards, so it stimulates the decremental conduction. It stimulates the slowdown portion of the AV node, but it doesn't matter. It's running backwards. In fact, there's some research that says it can actually make the rate of ventricular contraction go worse or go faster, so you could actually kill the patient by doing this. Carotid massage, where there's a New England Journal of Medicine out, I think in 2017, chiropractors and physical therapists and such should not be doing carotid massage in their office like they used to do. You can. It doesn't happen very often, but you can spark a ventricular tachycardia in some people and kill them. And we got. I think I left those slides in. We'll take a look at those here in a second. Okay. All right. So I guess we can take our break now. Maybe I'll split this up into 2 videos. Or this isn't live, so I guess you can pause it anytime you want, right? But I'm going to take a break, so I'll be back. All right, I'm back. So here we just talked about AVRT, atrioventricular reentry tachycardia. Now let's talk about the king of supraventricular tachycardias. If you're going to go out and drink Walt May's moonshine and the next day or the day after your heart starts racing like crazy, number one culprit is going to be AVNRT. This is the number one cause of supraventricular tachycardia. Okay, this one is not seen like junctional tachycardias quite often are in diseased hearts. This one is usually not a diseased heart, so that's good. Same with the Wolff-Parkinson. I don't think I said that about AVRT. They're usually not a diseased heart either. They just have a darn bypass tract of some kind, usually Wolff-Parkinson-White Syndrome or Langerhans-Levin syndrome. Same with this. Your heart isn't diseased usually in this condition. Could be after a heart attack, but usually not. It's considered a benign arrhythmia. It does not seem to decrease the chances of survival in the long term. Lifespan tends to be just as good. And what is it caused from? This is caused by the fact that these people are born with not one approach tract, like most people have one approach tract to the AV node. These people have 2 approach tracts, and they have to have weird physiology, these 2. One is a fast conductor, one is a slow conductor of the impulse, and we'll get into that in a second. Surprisingly, almost like a patent foramen ovale, probe patent foramen ovale, right? Isn't that about 20%? They never get welded together, so they have a pressure closed foramen ovale. Same thing here. So 20% of people have a second approach tract to the AV node. So some studies up to 35%. So what? What does that mean? Well, the second approach tract may never result in a tachycardia, but it's got to be a perfect storm, and we're going to look, and you can guess who that perfect storm is caused by, and it's another ectopic foci somewhere. So here's just a cartoon of it. Normally people have one, and this is way exaggerated, right? They'd be little stubby little fibers where the internodal pathways hit, and usually the signal comes into this fast approach tract from the atria depolarizing. Other people, 20%, have a second approach tract. It goes right down the triangle of Koch, or Cook, some people say. So that's where, remember I told you we had to learn that the anatomy of that right atrium a little bit more so you understand where that path is. So let's take a look. Here's that kind of right view of the heart with the right wall of the ventricle removed. We've looked at this. Inferior vena cava comes up through here. There is the foramen ovale, or that used to be the foramen ovale. Fossa ovalis is what it's called now. Uh, but anyway, so we had the eustachian valve coming off the inferior vena cava, and then we had the tendon of Todaro, which is a ridge right here. Remember the triangle? Then we had kind of an imaginary line going kind of through the coronary sinus, and kind of this part ran where the orifice of the right atrioventricular, the hole between the right atria and ventricle was. That's the triangle of Koch. And in 20% of humans, well, 80% of humans, there's nothing here. 20% of humans, you have a slow tract, but it's way faster than slow cell to cell spread. I mean, it's a tract. It can go fast. This is super fast. So most people, the signal from the SA node, which would be up in this region, it comes into the fast tract. It may come over here too, but this is a turtle. This one, the current's going to zip down here, go through the AV node. But in patients with this double approach tract, the current, half of the current will turn up here, and it'll collide with the slow tract, and these get snuffed out. And so that's the way you could run your whole life like that, not even know you have this. So it's kind of everything I just said. So fast tract usually conducts the impulse. But the key is, and if it doesn't have this slow repolarization, you won't get AVNRT. You have to be really fast. The fast tract conducts really fast. Where's that thing? So current action potentials can zip down this really fast and hit the AV node. But it's slow to repolarize. It doesn't reset. It's slow resetting. Where this slow tract, it's kind of slow conducting. I mean, it's still way faster than the tissue around it. But it's lickety split repolarizing. As soon as the current gets to here, this is already repolarized. So it's a super fast repolarizer. If you have that situation, then you're going to have trouble with AVNRT. Okay, so that's pretty much everything I just said. So what? Now we have a perfect environment for developing a reentry circuit. And we'll show you exactly how that works. And everything we said, normally the SA node moves down slowly, or starts down both the fast and the slow tracks, but it reaches the fast track much quicker. Some of it turns around, comes up and collides with that slow signal. And that's the way it goes. Let's look at a picture. So here's a cartoon. Everything I kind of said already. So here's the SA node generated a current. Everything's great. It gets in the fast track and zoom, it goes through here so fast. And here's the turtle. It's coming down, but it's so slow. The fast track has already hit the AV node, and some of the current has said, oh look, here's some more fiber. Let's go up and see where they go. And it goes up and there's a collision and these two currents are knocked out. Some of you are going, oh, I see exactly what's going to happen. But yeah, so they run and there's a collision and you probably never ever know that you have this double track situation. Okay, everything just kind of blown up again. Right, so, but remember, this fast track is very slow repolarizer. This guy's already repolarized, which is unusual. Super fast repolarizer. But there's nobody to set it off again until the SA node counts down and sends a signal and the same thing happens again. This fast track always beats it. Part of the signal goes to the AV node. Part of the signal goes up here and knocks out that slow moving, I guess we could call it a rebel current if you want to call it that. So how does the AVNRT get started? Again, perfectly placed premature. It could be a PJC as well. It doesn't have to be just a PAC, but we'll use a PAC this time. And it occurs, well, let's show you. We'll show you in the diagram. But it occurs near the entrance to both tracks, but one is repolarized and one isn't. Right? And the fast track can't accept the pack, the rebel current, or the current from the pack, but the other one can. And Yeah, so the SA node potential. Let's go to the picture. Where's the picture? All right. So here's the deal. So the SA node has generated an impulse. All right, that's already went through the normal system as we said. That's in blue, so I didn't draw that in. But here's the impulse from the last SA node. It's going to run the heart. But before the SA node can spark another one of these blue signals, a premature atrial contraction, an ectopic foci occurs right here. The signal has just went down both of these tracks, and it's already snuffed out like it usually does. But remember, this fast tract is a fast repolarizer or slow repolarizer. Slow repolarizer. So this can't accept a current right now. It's still repolarizing. This guy's ready to go. So what happens is the pack depolarizes here. It's like the SA node. It sends out a wave of depolarization everywhere, knocks out the SA node, so that can't send a current out again. It hits the fast track, but the fast track says, I can't accept you. I'm still depolarized. I'm not repolarized yet. I can't accept you. It hits the slow track. Slow track says, I can accept you. And here's the rub. So now there's nobody to knock out the rebel current here, or the slow current. And it goes, I mean, not that slowly. It can go 180 beats per minute. So, I mean, I'm just trying to get this in your mind, but it's not that slow. It can go fast. But it goes down here, and it says, okay, great, yay, we won. Let's depolarize. Let's get into the slowdown portion of the AV node. It's going to run the heart that way like normal, but it goes, oh, look, here's some fresh territory. And now this is finally depolarized. Why this current was moving down here, this one finally got depolarized. This can't be depolarized here because it hit and it canceled out. It hit this and it just snuffed out. It wasn't ready at that time. But as this went down here, now it's repolarized. So this current is able to race back up, backwards the fast track, and pop out here. And it's just like an SA node. It spreads everywhere. It goes, knocks out the SA node, and then it travels right back down here again because this is a fast repolarizer. And so you get a wicked little current, and I mean it can run like 180, 200 beats per minute. And some people, it all depends, how your physiology is in here. But you got yourself a macro reentry circuit here racing around this anomalous slow track. So where's the retrograde and anterograde? It's going, and this is for medical people, nurses, whoever's taking this, make sure you know it goes anterograde down the slow tract and retrograde backwards up the fast tract, and that's the way the loop goes. Okay, that's atrial nodal AVNRT, reentry tachycardia, number one cause of supraventricular tachycardia. Right, and there I tried to show you there's nothing to stop the current. Right, maybe another PAC will come along and snuff everything out and give this time to reset. But it doesn't always happen. You might have to go try the vagal maneuvers. You can use those on here, but again, as we'll see in a minute, chiropractors shouldn't be using those in your office because you could, it's rare, but you could kill somebody. Could stimulate a ventricular tachycardia unless you're an EMT and trained how to use defibrillation. You better not mess with it. All right, that's AVNRT. What are the clinical features? So the heart typically runs about 175 beats per minute. Some cases it's been way over 250 beats per minute. It's not comfortable, your heart running. I mean, you'll wreck your ventricles. You can't let your ventricles run that fast forever. It's got to be slowed down. One way to tell it apart, it can be hard to tell apart from junctional tachycardia. This is the one, and junctional tachycardia are really tough to tell apart because they both like to slur that S wave, inverted P wave in the S wave. But one way to tell apart is the speed. For our purposes, junctional tachycardias aren't going to go more than 130, 140 beats per minute. All right, so if you see one going 175 beats per minute, even though it looks like a junctional tachycardia, for our purposes, it ain't. Okay, these are often called paroxysmal. They tend to stop by themselves out of the blue sometimes. They can start out of the blue sometimes. But although we know, really why they start, because of a perfectly placed, uh, and a PJC could do it as well, right? How would a PJC do it? Well, what if I don't have a good drawing? I guess I didn't do drawing. But what if this did come down here and you had a PJC run backwards? What if a PJC occurred right here? Or what if a PJC occurred, premature junctional complex occurred here and snuffed out the current, maybe the current made it in both of these tracks like normal, and it's going down the slow and the fast, but a PJC occurred here and snuffed it out? You'd get the same result, right? Nobody to stop this. Anything that stops this current from coming down and doesn't stop the turtle from coming down, if the turtle makes it down, you could get this AVNRT. Okay, still easy to confuse, with junctional tachycardia in reality. Kang, K-A-N-G is that book I was reading. I don't like that book, by the way. It's first edition. I don't think they reprinted it, but boy, it's got a lot of rhythm tracing. It's more like an atlas, but boy, it's a terrible textbook. Sorry, but that's true, in my opinion. Let's see. Yeah, it could go on for seconds and stop. It could go on for minutes. Could go on for days. You got to get this one slowed down, though. You'll wreck your heart if you let your ventricles run that fast. Okay, the current is using the AV node. So if you do a tracing and don't see that wide tachycardia, it's safe for medical professionals to try vagal maneuvers to see if they can get this thing. And you got a chance to stop it because the current is going through the AV node. So you got a chance to stop it that way. EKG findings, very similar to a junctional tachycardia. P waves are typically upside down, inverted. They typically show up, or they don't show up before the junctional, the QRS complex. About 50% of the time, the P wave is hidden behind the QRS complex. Very difficult to tell apart from PJC or from junctional tachycardia. Other 50% of the time, the P waves are distorted, causes a pseudo S wave or a slurred S wave. We talked about that with junctional tachycardia. So tough to tell. How can we tell it apart from junctional tachycardia? By the speed. That's what we're going with for our class. QRS complex is typically normal, so the duration won't be greater than 2.5 little boxes, 2.5 millimeters or 10 seconds, whatever you want to talk about. Okay. Another phenomenon, sometimes when you're looking at a tracing, you see, what do you guys think? Dan, haven't heard from you. Come on. What do you think of this? That's normal, right? Another normal beat. Look at the RR intervals. So normal, then we got a premature beat or something happened here, and now we got a tachycardia. So sometimes you get, that was the PAC right there, but before the tachycardia starts, you get this really long PR segment, PR interval. And so that's quite characteristic of the start. Junctional tachycardia don't start like that. That's another way that you can tell the difference between these. So early PAC starts the AVNRT. Yeah. We got a little slurring, kind of hard to see the pseudo S wave in there on this cartoon. All right, 53-year-old enters with pre-syncope, kind of dizziness, mid-back pain. In the history, you found he has chronic bronchitis, which is one of the COPD clusters. What's the other COPD cluster? There's two of them that make up the diagnosis. They're always mixed together. Not chronic asthma, some of you medical students, even though the medical pathology books do include chronic asthma as part of COPD. Chiropractic books, Robbins and Rubens, don't. So it's chronic bronchitis and emphysema. Those two are always mixed. So he's got some lung problems going on here. So you run an EKG tracing. Okay, you guys, what do you think here? Pause it. Take a look. look at that axis. How's the axis doing too? All right, we're back from pausing it. So what do we see? How's the R? Oh, I cut off the rhythm strip. Let's look at 2 for our little short rhythm strip. Our waves are cool, right? They're not there's no PVC or there's no PACs going on, PJCs. They look pretty good. What's the speed now? I guess we'll have to use this one's right in the middle box. So there's 300, it ain't 300. It's over 150. It's probably faster than a junctional tachycardia. Okay, where's the P wave? Is that the P wave? No, it's T wave. QRS complex T wave, QRS complex T wave, QRS complex T wave. Little funky going on right there, yeah? I bet that's the P wave notched in the S part of the QRS complex. So what do you think it is? Based on our rules, a little too fast for junctional tachycardia. So this is probably, because of the slurred S wave, it's probably AVNRT. In reality, pretty hard for most humans, not electrophysiologists. They probably have their ways. Don't see any YouTube videos by them. Be nice to see a more in-depth one, but I guess people don't care about much deeper than I'm going. But yeah, it's going too fast to be a junctional tachycardia. So this is probably because of the notched slurred S wave. It's AVNRT. What about that axis though? You guys are good enough to do that in your heads now? Limb lead 1 is biphasic. Where's limb lead 1? That's right at 0, right? That's stick your left arm straight out at 90 degrees. That's 0 degrees. So it's either heading toward the North Pole or South Pole. Actually, it's a little different. So remember to draw the perpendicular. So is it heading more toward the South Pole? If it's heading toward the South Pole, who should be positive? Well, who's the peeper, right? AVF. Is it positive? Yeah. How about AVR? It should be not perfectly negative, but mostly negative. Yeah. So the current is flowing down. It's flowing down. This, because of this little hump here, it says it's actually heading somewhat away from it. So this guy is going probably right toward limb lead 3, the axis. And sure enough, limb lead 3 is pretty high. So that matches the COPD pretty good. Okay, just blew it up for you. I guess we could have worked with that one. But everything we said, that's not right? That should be built with a straight edge, and there's an extra line in there, so that's a notched P wave, or a slurred S wave. The P wave is in the S wave. Yep, slurred, everything I said. It's running 150 beats. It's AVNRT. Reality, it could be a junctional tachycardia, but for our testing purposes, it's a little bit too fast. What about, I did do this. Okay, what about the axis? Everything I said already. We're going to use limb lead 1 as the most biphasic. So we're going to use limb lead 1 as the camera. Limb lead 1 is right here. So step 1, draw the line. Its angle of orientation is looking straight this direction. So we draw that in. Then we draw perpendicular without drawing the arrow, because we don't know which way it's going. That to determine which way the current is running, we had to look at, we don't have a lead up here at -90, but we have one down here at 90 degrees, which was AVF. If that's positive, the QRS complex is positive, it's heading pretty close to right at it. It's not perfectly positive, but pretty close. So if we know the current is going this way, we go back to this lead and we look to see if it's perfectly biphasic. Is it perfectly biphasic? No, it's not. It's shorter here. It's more negative. That means it's heading towards or away from limb lead 1. It's heading slightly away from limb lead 1. So it would be heading right at limb lead 3 actually. Alright, and that's what it was. So we have a right axis deviation, which means her her right ventricle is probably enlarged. She probably has cor pulmonale started, so send her to a pulmonologist. Another one, 49-year-old developed dyspnea and palpitations after a basketball game which continued for 4 hours. She has a history of hypertension since 18. Probably not the greatest at taking her meds. What do you think? Oh, there's some funkiness going on here, right? You can see there's a P wave notch. But let's go through our procedure. Our intervals look fine. Is it a tachycardia? Oh, that one's a nice lined up for us, isn't it? 300 if the other R wave would be here. No. 150, a hair under 150 it looks like by that rule. Definitely a tachycardia. I don't see a P wave. Looks like the P wave is here. 150 is a little too fast for junctional tachycardia. It's AVNRT again. Okay, we're getting pretty good. Ready for the test. By the way, I have to do the test, as you know, has to be on the quiz function of Brightspace. It's not going to be written. You thought you got out of these EKG tracings. That's not true, because I just did the spinal anatomy wet lab with pictures. It accepts pictures. So you better be ready for these EKG tracings, because they will be on your final. Can't escape them. Treatment, vagal maneuvers, yeah, that'll work. By these things, you could terminate at 19% of the time. By when it's kind of an older study. There's probably a more recent one, but I didn't take time to search too much. Why? Because part of the reentry circuit is the AV node, so you can stimulate the AV node with these vagal maneuvers and knock this guy right out. Here's the warning about carotid massage. So I saw this in New England Journal of Medicine in 2017, so I've been warning students about this since. There are contraindications for carotid massage. So history of a TIA or stroke in the last 3 months. You better get your stethoscope. If you're going to monkey around and do carotid massage, you better get your bell of your stethoscope over the carotid arteries. So auscultate for bruits, or get your ball of your metacarpal phalangeal joints over there and see if you can feel for thrills, turbulent blood flow. But it's contraindicated. Don't do it. You could break a piece of plaque off. Go up into the noodle, cause a stroke. Carotid stenosis, you wouldn't know that without an ultrasound. If they've had a myocardial infarction in the last 3 months, don't do it. If they have a history of any ventricular arrhythmia, don't do it. If you're a chiropractor, why risk your license? Send them to the ER, unless you're an EMT as well. And there's another, a 2.5, this Deepak also came to the same conclusion, wrote I think it was a couple case studies about this. But they did run-of-the-mill carotid massage and people died. They went into ventricular fibrillation, which you better have paddles around or the patient's going to die from that. Okay, so it's really designed to be in a hospital. Chiropractors should not do that in their office. The symptoms, they're the same, maybe slightly more severe because it's myocardial is cranking, but the same old symptoms as the other supraventricular tachycardias. Palpitations if they feel the heart racing. They might become anxious. They may be dizzy if the ejection fraction's affected. What's the treatment? Vagal maneuvers, but if they fail, adenosine, drug of choice, near 100% success rate according to ISA with this. So usually you don't have to go to the electrocardioversion, but a pharmacological cardioversion, which is administering adenosine, if that fails, electrocardioversion will be employed. Usually synchronous current is good enough. You don't have to go to the defibrillation panels, but maybe occasionally you do. Hey, we made it. All right, I'll get this posted up on YouTube. This will be on the final. So we still got some more work to do, right? We got a lot of lectures. So I better rest my voice and I'll get gastrointestinal pathology is up next.